Hello everyone, I hope and I believe all of you are fit and fine. So today we learn about neonatal hypocalcemia. So here we go. 99% of total calcium is in our skeletal system, our bones. Only 1% calcium is in extracellular fluid. Among 1%, 50% calcium is ionized calcium, which is active form. 40% calcium is bound with albumin and 10% complex calcium bound with citrate, lactate and phosphorus. Ionized calcium is the main active form of calcium in the blood, which is responsible for muscle contraction, various types of signaling between the cells. While serum calcium level is not accurate in the first week of life because it is affected by low serum albumin level, and for every 1 gram per deciliter falls in the serum albumin, total serum calcium level falls by 0.8 mg per deciliter. So, ionized calcium is done for accuracy. We should also remember that false low ionized calcium is seen in case of alkalosis and heparin contamination of the blood sample. So, here we can see that mother to fetus calcium active transport occurs 80% in the third trimester and only 20% in first and second trimester. So here preterm babies have major loss. Maternal to fetal calcium ratio is 1:1.4. So fetus has benefits. Most important factor which decides maternal to fetal calcium transfer is PTHRP, which is parathyroid hormone related peptide. It is produced by fetal parathyroid gland. So, my question is, when it is called neonatal hypocalcemia? In preterm babies, total serum calcium less than 7, and in term babies, total serum calcium is less than 8. And ionized calcium in preterm less than 4 and in term less than 4.8 mg per deciliter. It is called neonatal hypocalcemia. Here we can divide neonatal hypocalcemia in two parts, early and late. If it occurs in first 96 hours of life, it is called early hypocalcemia. It is very common and usually asymptomatic. If it occurs after 96 hours of life, it is called late hypocalcemia, usually symptomatic and relatively rare than early hypocalcemia. So tell me the causes of early onset neonatal hypocalcemia. First and most common cause is prematurity. Why prematurity causes hypocalcemia? So due to premature stoppage of the transplacental calcium transfer to the fetus, due to increase in the calcitonin level, and due to decrease in the responsiveness of the tissue to the PTH axon. Second cause is perinatal asphyxia. Why perinatal asphyxia causes hypocalcemia? So, due to delayed feeds, increase in the phosphate level due to tissue catabolism, due to deranged renal function in asphyxia, and due to decrease in the PTH activity in case of asphyxia. Third cause is infant of diabetic mother. Due to macrosomia in these infants, it increases the requirement of calcium, and in these infants, decreased magnesium level leads to functional hypoparathyroidism in the first week of life, and it causes hypocalcemia. Fourth cause is maternal anticonvulsant like phenytoin and phenobarbital consumption. It interferes with maternal vitamin D metabolism, and hence it causes neonatal hypocalcemia. Fifth cause is maternal hyperparathyroidism. If maternal PTH is high, then maternal calcium level is also high, and it suppresses the PTH activity in the baby. So it results in neonatal hypocalcemia. Sixth cause is iatrogenic cause. When we giving bicarbonate therapy in metabolic acidosis in the baby in the first week of life, it can cause alkalosis and it results in decreased ionized calcium. When we give phototherapy to the neonatal jaundice baby, it causes decrease in melatonin and increase in the calcium level in the bones. So it further decreases in the calcium and results in early neonatal hypocalcemia. When we do double volume exchange transfusion therapy in the baby, citrate inside the blood products chelates the ionized calcium, so it results in hypocalcemia. Generally, hypocalcemia in the neonates is asymptomatic, and symptom, if at all it occurs, it is non-specific like poor feeding, vomiting, lethargy, tachypnea and apnea. In neuromuscular irritability, patient can occur jitteriness, seizures, myoclonic jerks, exaggerated startle response. Cardiac features are tachycardia, CCF, arrhythmia, prolonged QTC interval more than 0.45 seconds in ECG, and decreased cardiac contractility. So my question is, how to treat early neonatal hypocalcemia? So if patient is asymptomatic, give oral 10% calcium gluconate 8 ml per kg per day, which is 80 mg per kg per day for 48 hours, and then half the dose means 40 mg per kg per day for 24 hours, then stop. If it is symptomatic early neonatal hypocalcemia means patient has jitteriness, seizures or CCF, any kind of symptoms, then we should give 10% of calcium gluconate IV bolus 2 ml per kg diluted in 1:1 in 5% dextrose and give over 10 to 15 minutes slowly and under ECG monitoring, because it can cause bradycardia and arrhythmia, and further followed by continuous IV infusion of 80 mg per kilogram per day for 48 hours, and then half the dose 40 mg per kg per day for 24 hours and then stop. Now we will see late onset hypocalcemia. If it occurs after 96 hours of life, it can cause late onset. It can cause due to increased phosphate load, due to cow milk consumption, or due to renal dysfunction or CKD. Vitamin D deficiency in case of vitamin D dependent rickets type 1 and 2, hypomagnesemia, malabsorption, hepatobiliary disease, PTH resistance, autosomal dominant, hypocalcemic hypercalciuria, hypoparathyroidism, primary and secondary type, and iatrogenic cause due to loop diuretics, bicarbonate therapy, steroid or citrated blood products transfusion. So apart from total serum calcium and ionized serum calcium, we can investigate for serum phosphate level, magnesium level, RFT, LFT, ALP, PTH level, ABGA, chest X-ray, vitamin D level, urine calcium create ratio and maternal calcium profile. You ordered all the investigations, okay? Now, how to interpret this all investigation? Let's see together. Before that, just remember two sentences. Always remember PTH and ALP level go hand in hand, and vitamin D level is low in all the cases described here except vitamin D dependent rickets type 2. So first we see hypoparathyroidism means hypo PTH means low level of PTH, therefore low ALP level also, and vitamin D level low is in all the cases, and high level of phosphate in this case. Next is pseudo hypoparathyroidism. Pseudo hypo means PTH level is not low, PTH is high, therefore ALP is high, phosphate is high, and vitamin D level is low. Next is CKD. In CKD, vitamin D level is low, calcium low, therefore high phosphate. PTH and ALP level is high due to low calcium, and there is deranged RFT, and there is metabolic acidosis, so pH is also acidic. Next is hypomagnesemia. In hypomagnesemia, calcium, phosphate, magnesium and vitamin D, these four are reduced and only PTH level is high. Next is vitamin D dependent rickets type 1. In this case, vitamin D level is low, phosphate level is low, calcium level is low. In response to this, PTH and ALP level becomes high. Next is vitamin D dependent rickets type 2. In this case, vitamin D resistance, peripheral resistance in receptors can be seen. So here vitamin D level is actually normal, but its excess are absent. So it's looking like vitamin D deficiency and looking like rickets. But in actual, vitamin D level is normal to high, PTH and ALP levels are high, but phosphate and calcium levels are low. So what can we do for late onset hypocalcemia? Same as early onset hypocalcemia, but in case of hypomagnesemia, Injection magnesium sulfate 0.2 ml per kg, 50% MgSO4 intramuscular. 2 doses are given 12 hours apart and followed by maintenance dose of 0.2 ml per kg per day orally for 3 days given. In case of high phosphate level, encourage exclusive breastfeeding and avoid animal milk. Phosphate binders cannot be used in case of neonates. In vitamin D dependent rickets, activated vitamin D, that is calcitriol, 30 to 60 nanogram per kilogram per day can be used. Thank you.